Yeah, so I would say that there are, a lot of systemic pressures that would drive physicians to frequently request exceptions. Um, as people might know, the etiologies of advanced heart failure and the indications for heart transplant among kids are extremely heterogeneous, but the OPTN right now categorizes all of these kids using only three status categories. And we actually showed in our paper that about 60% of kids at initial listing have the top priority. So essentially, it's basically a first come first serve kind of game. Um, there are some other vulnerabilities that children face that are very unique to pediatric heart allocation. There's severely long wait times, particularly by different weight and blood type. One of our co-authors is a pediatric heart transplant cardiologist at Boston Children's, and he mentioned that it's not uncommon anymore to find that kids are waiting for months and even longer than a year for a heart. So I think exceptions are kind of seen as a way to work around these huge constraints that are in place by the three status system. Yeah, so ultimately, my co-authors and I were very strong proponents for a completely reimagined medical urgency score. We've shown in our paper, and many other papers have shown before that the three status system just doesn't work. Um, there's some evidence showing that, you can have continuous medical urgency scores that are based on laboratory values that works for liver allocation, even for adult heart allocation. There's a paper that's recently come out about that. So I don't think there's any reason to believe that pediatric allocation couldn't be serviced by a similar score. So I think that will probably be the main change that we'll be vying for by the OPTN. Yeah, so I'm not a pediatric cardiologist, so I haven't taken care of any pediatric patients waiting heart transplant. But as a general surgery resident, I can certainly understand that there are some immense pressures that these physicians can feel. As physicians, we have the duty to do what is best for our individual patients, but I think transplant physicians have an even bigger conflict. There's a conflict between that ethical obligation and then an obligation to society, which is making sure that very scarce donor hearts go to the people who need them the most in a fair and efficient manner. Um, so I think in the midst of a really poorly working three status system, exceptions might be appearing as a workaround to allow physicians to basically support their patients in to even give them a small chance of getting a heart. Um, and I think they're just doing their best to advocate for their patients in the setting of a poorly working system. Yeah, so we had performed that analysis to show kind of just how bad the situation is. In the way that we designed it, the system would literally be more accurate in rank ordering kids by their mortality risk if exceptions didn't exist. But I really appreciate this question because we never intended it to be proof that exceptions should be eliminated. Um, I don't think there's no such thing as a perfect algorithm. So for example, even as good as the MELD score is for liver allocation, there are still exceptions that exist because not every case can be well captured in terms of risk profile by the MELD score. There's patients with liver cancer, there's patients with metabolic disease and liver allocation that just are not captured well by MELD score. So even if there is a MELD-like score for pediatric heart allocation that exists in the future, I don't think that means that exceptions will not be there. Exceptions should be rare in a functional system, but they can't really be um, eliminated. Yeah, so this paper is now the second paper to come out in JAC within the past few years to document the major problems of pediatric heart allocation. These are pretty high profile papers, and I think they'll have a lot of visibility within the field. I'm hoping that we can work with the OPTN to consider reevaluating the three status system. Um, as you can imagine, creating a new score like MELD for kids who need a heart, it's going to be a massive effort. The first thing we need to have is actually the actual data, which are not currently collected by the OPTN in the same way that it is for adult patients. And the reason why I say this is, in the past decade, there's been two major heart allocation policy changes for pediatric heart transplant candidates. There was one in 2016. There was one in 2021, which created the National Heart Review Board. But the problem with those two policy changes is they respected and basically kept the structure of the three status system. And our paper and the prior Jack paper, which came out also from Stanford, showed they didn't really have a meaningful impact. I think waitlist mortality will continue to improve as technologies improve. It used to be more than 20%, and now it's 12.5%, but it's still very, very high. Um, and I personally think that going to the real basics and ensuring that we have a really outstanding medical urgency score is going to be the real watershed moment. Yeah, I think one final, note I wanted to make is, I think our paper really showed that exceptions, they're mainly in candidates who are low wait lists, who have low wait list risk of mortality. Um, But merely, the way we wanted to frame the paper is that exceptions are almost a symptom of an underlying problem, which is that, the medical urgency score, the three status system has a lot of issues. And I think exceptions are kind of being used as a way to work around those constraints. I think we try to frame our paper in a way that doesn't blame people for using exceptions, and exceptions certainly aren't the main problem.